differential income between general practice and some specialties is a really big problem. You know, I mean, if you're sitting down there and you're looking at your career options and you see what you get in general practice and you see what you can get in a specialty, if the gap is really big, then that's always going to be a challenge for us. So I think narrowing that remuneration gap between general practice and the specialties is one thing.
Is that changing, say, the balance of the procedural rebates with the more consultative rebates, or?
Potentially. I mean, obviously, if you pay really well for procedures and you don't pay much for consultation, then you're going to get a lot of procedures happening, which we see, which may not necessarily contribute a lot to the patient's overall health and well-being at the end of the day. An important part of medical practice, but we shouldn't be procedure driven because that's how you make your money. I think that consultation needs recognition that if you actually spend time with a patient, that you can take a really good clinical history, you can understand the patient's context and their psychology, and all of that may mean that there are less investigations ordered, less procedures. It's a much more cost-efficient way. I think that the money for registrar and PGPP supervision is adequate. I mean, we're not as concerned about that. The main issue has been around the increasing number of medical students, and that's been supported through PIP payment, but it's quite restrictive. So I think that's an area that we would like to see improved. There's an infrastructure issue. General practice is changing. We're now having lots of new members in the team, and that's something that the government wants. We've got nurses, we've got allied health practitioners, we've got psychologists, and they're all contributing in a positive way. We also are training more people, and you just can't do that if you've still, only got the same number of consulting rooms and there's no space. So infrastructure is definitely a limiting factor. We have a good model in a lot of rural Australia where GPs do procedures in hospitals. One of the issues though is that a lot of small rural hospitals get closed. So we train GPs to be able to perform procedures, and then the opportunity for them to actually do that can disappear. So I think it's really important that we are working with state health jurisdictions as well to make sure that if we're pushing training for GPs to get procedural experience, which everyone recognises is a really good thing, that we also maintain those opportunities for them to practice those skills. Now, in terms of the city, I mean, we know that GPs are very efficient in not just financially, but also in terms of the patient journey, because we have a much better understanding of our patients than probably anyone else, and that's because we have a long-term relationship. We see them in the context of their community, we know their families, and we also know their priorities a lot of the time. So we're best placed to make a lot of decisions. I think particularly if you start looking towards the very end of life care, where a lot of the expense happens in hospitals, that's where there's a real opportunity for general practice around things like palliative care, but also we're pushing advanced care directives and getting the GP involved in those sort of consultations. And I think that for GPs, that's quite an exciting opportunity for us to start to step a little bit back into the hospital sector in a metropolitan setting as well.